These are the factors that impact blood pressure. Blood volume. Okay? We can think of all the blood vessels as being a big vascular container. If you put more volume inside that container, what happens to the pressure inside? It increases. So volume is one of those factors that determines blood pressure. A second is peripheral vascular resistance. So in this slide, we're using the term PVR to indicate peripheral vascular resistance. A better term is SVR, which stands for systemic vascular resistance. It's a better term because PVR can be confused with pulmonary vascular resistance. Systemic vascular resistance is basically resistance to the movement of blood. It's determined largely by the drag or friction created as blood moves along the walls of a vessel. Okay? Now, the smaller the lumen of that vessel, the more contact between the blood and the walls, the greater the degree of drag, the higher the systemic vascular resistance. Okay, the resistance to blood flow. And so, if a vessel is vasoconstricted, okay, then its SVR is higher. There's more resistance to blood flow. Okay? In this case, blood pressure goes up. On the other hand, if that vessel undergoes vasodilation, SVR falls, blood pressure falls. So that's the second factor that impacts blood pressure, systemic vascular resistance. The third is cardiac output. Remember we said cardiac output is heart rate times stroke volume. Okay? So if heart rate increases and our stroke volume increases, blood pressure is going to go up.
We talked about that in forum.
What's that?
We talked about that in forum.
Yeah. Yeah, on the other hand, let's suppose someone's in congestive heart failure. And instead of their heart doing this, it's contracting like this. Well, that's going to affect stroke volume. In that patient, stroke volume is going to fall, and so will blood pressure. Okay? Every drug that we use to treat hypertension works by impacting one of these three factors. For instance, oftentimes a first-line agent for the treatment of hypertension is a mild diuretic. Okay? By decreasing intravascular volume, you're going to lower pressure. Sometimes we'll use drugs that are beta blockers that work by decreasing the heart rate, decreasing the stroke volume. Well, what they're doing is reducing cardiac output. Sometimes we use drugs that are vasodilators. What they're really doing is expanding the vascular container. Same amount of blood, but in a bigger container. Pressure's going to fall. There's less drag. Now, you can measure blood pressure either directly or indirectly. If you were going to go for cardiac bypass surgery, the anesthesiologist would want to be able to keep a constant tab on your blood pressure. So what that person would do is they would find your radial artery, like this, palpate it, and then throw a tiny catheter in it that was connected outside to some type of pressure transducer. And so you could get a constant read of the blood pressure. That would be a direct measurement. Is that the most common way in which we measure blood pressure?
No.
No. We measure it indirectly using an instrument called a sphygmomanometer. Okay? Sphygmomanometer. So that could be a word that you would have to say, sphygmomanometer. Okay. Alyssa, can you say sphygmomanometer?
Make no manometer.
All right, so we could not give you credit for that. When you say, if we have this in a practical, it's got to come out the same way as you would say it, let's say in a clinical setting, the way you would ordinarily talk. So if in a hospital, you were talking to a nurse and you said sphygmomanometer, you would think there'd be something wrong. Are you okay?
Trouble.
Sphygmo. Give me a
Yeah, I need
sphygmo.
Okay. So I think everyone here is familiar with this. This is a sphygmomanometer. This is one of your classics. This is old school. They all include, I got too much stuff going on here. They all include a pressure gauge, a cuff, a bulb, and here a little screw or knob that regulates how much pressure you put into the cuff. Okay. So what we're going to do is, typically they have a little marking like this here that you can position over the brachial artery. So now I would have to roll up my sleeve, but I would position the cuff such that this little marking is situated just above the brachial artery. And in that position, I would use this Velcro then to secure the cuff around my arm. Now, at the same time, I would put the bell of the stethoscope, distal to the cuff, over the brachial artery. Before the cuff is inflated, will I hear any noise within the stethoscope?
No.
No, because blood flow is laminar, as long as that vessel is not compressed. Okay? But once I begin to compress that vessel slightly by inflating the cuff, okay, by applying external pressure, then I have turbulent blood flow, which creates what are called Korotkov sounds. I'm going to get ahead of myself here. We'll come back to those other slides. So the first time, this is the proper way to do it, although I realize that most people skip this first step. What you're supposed to do, what you learn how to do first when performing blood pressure measurements, is to use your hand and palpate the brachial artery as you're inflating the cuff. That point at which the brachial artery pulse disappears is the systolic pressure, okay, by palpation. Okay. I deflate the cuff then. All right, the next go round, I'm going to use the stethoscope. I'm going to put the diaphragm of the stethoscope over the brachial artery, and I'm going to inflate the cuff 20 millimeters above that systolic pressure that I palpated. So if I palpated the loss of the pulse at 120, I'll inflate the cuff to 140. Okay? Now, when I inflate the cuff above the systolic pressure, let's say here's the systolic pressure, here's cuff pressure, that's going to completely compress the brachial artery. So that, will we have any blood flow? No. Once I reach that pressure that's 20 points above systolic, I slowly release the knob to allow pressure within the cuff to slowly fall. All the while, I'm looking at the pressure gauge as it goes from 140 to 130. When I reach 120, okay, or less, okay, there is now the vessel is beginning to open up, just slightly. And with that, during peak systole, blood is passing through the vessel now. And as it passes through, creating turbulent blood flow, I'll start to hear a sound. That reading, at which I first hear that sound, that Korotkov sound, that's the systolic pressure. That's the point at which the cuff pressure is equal to systolic. Now, as I continue to deflate the cuff, that Korotkov sound may get a little louder. Maybe go from like that with each contraction. When I deflate the cuff to the point where it is below diastolic, that means that at no point during the cardiac cycle is the vessel compressed at all. Now blood flow is laminar. At this point, when the cuff is below diastolic, the sounds disappear. So when obtaining a blood pressure measurement, as I'm deflating the cuff, the point at which the Korotkov sounds first appear is the systolic reading. The point at which they disappear is the diastolic reading. That's it, right? Systolic, diastolic. Okay? So that's the more common way in which we measure pressure. Now, we said that when we do a blood pressure measurement, we record a systolic and a diastolic reading. There are two other forms of pressure readings that are important. The pulse pressure. It's simply the difference between the systolic and the diastolic reading. Example, if someone has a blood pressure 120 over 70, the pulse pressure is the difference, 120 minus 70, 50 millimeters of mercury. They call it the pulse pressure, obviously, because the higher that difference, the stronger the pulse. The more brisk the pulse is. If you have a very narrow pulse pressure, let's say 100 over 80, you're not going to have much of a pulse. It's going to be relatively weak. Okay? Because it's that difference as you go from diastolic to systolic that causes that pulsation. All right. Pulse pressure increases with exercise. As we exercise, our systolic reading increases. The diastolic generally stays the same or may even drop 10 points or so. So the gap between the two, systolic and diastolic, increases. Pulse pressure also increases with arterial sclerosis in larger arteries. We said that as a result of arterial sclerosis associated with aging, our vessels become stiffer. So when blood is pumped into the aorta and into its branches, those vessels don't expand to the same degree. So we have the same amount of blood, but in a smaller volume due to lack of expansion. That means the systolic readings are going to increase. Okay. On the other hand, the pulse pressure falls in conditions like congestive heart failure, or we're ejecting less blood, the stroke volume's less, or hypovolemia. Now, the other type of reading we can obtain is a mean arterial reading. Let's go back. The mean arterial reading, or mean arterial blood pressure, is equal to the diastolic blood pressure plus a third of the pulse pressure. So for instance, let's say someone has a blood pressure of 120 over 60. The mean arterial pressure would be 60 plus a third of 120 minus 60 is 60. So 60 plus 20, I think it's 80. Notice that it's only a third of the pulse pressure, not half of the pulse pressure. Okay, it's only a third of the way up to systole. Yes?
I don't know if this is true, but I've heard it before. I understand why high blood pressure is like important and it's always treated, but why don't they normally treat low pressure unless you have a lot of like serious symptoms?
Because low pressure is protective.
Okay.
It's high blood pressure that predisposes toward atherosclerosis.
Okay.
It's that constant stress on the vessels.
Okay.
Whereas low blood pressure is not going, it lowers your risk for
Okay.
things like strokes and heart attacks and vascular disease. So unless you're getting symptoms, low blood pressure is actually good.
Oh.
Okay, so this is just a couple of examples. We said 120 over 60. Joe has a blood pressure. What's his pulse pressure? Well, it's simply the difference, 60 millimeters of mercury. Mean arterial pressure, we use this formula. I just did it on the board. We get 80 millimeters of mercury. The diastolic blood pressure influences mean arterial pressure more because the diastolic time interval is longer than the systolic time interval. The heart, the blood vessels spend more time in diastole than they do in systole. Okay. If we look at blood flow and pressure, God bless. This is a chart that demonstrates blood pressure as we move from the aorta to medium-sized arteries, arterioles, capillaries, venules, veins, and then vena cava. You can see that there's a progressive fall in pressure as we move from proximal to distal. Okay, as we move from arteries to capillaries to veins. And also you should notice that blood flow within the arteries is pulsatile. We have a systolic and diastolic reading. Once we reach the capillaries, blood flow is continuous and steady. It's not pulsatile. Same thing is true within the veins, continuous and steady. Okay, because you don't have a systolic and diastolic component, you don't have a pulse pressure, you just have a mean pressure. There is no pulse associated with capillaries or veins.
Is it pulsing like that because of the elastic arteries, or is that just the heart?
Because of the
pumping?
elasticity.
Okay.
Okay, so these vessels expand and then they contract, recoil, pushing blood forward. Now, let's stop here and today, let's take out the microscopes. We'll pick up here at veins next go round. And I simply want you to look at some arteries and veins.
You tricked me so well.